Hello, this is Brian Willett, and I'll be talking about the strengths and limitations of the various techniques that are used during brain tumor resections to map and monitor the cerebrum. Talk about the decision versus awake versus anesthetized, the pros and cons, mapping cortex, the various techniques used for that, subcortical mapping, and then continuous direct cortical MEP monitoring. How does IONM help during a brain tumor resection? First, it helps to identify and map the functional eloquent brain tissue. And then it helps by monitoring during the resection to assess if there is any evolving dysfunction to help the surgeon in that clinical decision making as far as balancing maximal resection versus preserving function. So what are the important considerations? That the first thing is, should the procedure be performed awake or under general anesthesia? The next is appreciating the difference between mapping versus monitoring, and the difference between direct cortical MEPs versus transcranial MEPs. And also when mapping subcortically, how close you are to corticospinal fibers. So all cortical regions can theoretically be mapped, but speech and premotor areas such as SMA and any sort of related speech area, angular gyrus, Wernicke's region, they can be mapped, but they'd be mapped with assessing actual behavioral disturbances while the stimulation is being performed. Thus, if these regions are at risk, the procedure should be performed awake. The stimulation requires a short, sustained 50 to 60 hertz, 4 to 5 second stimulation. And this is designed to kind of abort an ongoing behavior. But this kind of prolonged 50 to 60 hertz stimulation can also produce a seizure. So there is an elevated risk of that. That's why the anesthesia teams in particular, need to be ready with ice cold saline and the drugs that would abort that seizure should it occur. And this is also why we record electrocorticography during these procedures to make sure to identify if there's any seizure activities starting to become evident in the ECOG. But for mapping under general anesthesia, ideally start with central sulcus mapping using phase reversal. This identifies the central sulcus, obviously, but also this then tells where the primary somatosensory cortex is, as well as the primary motor cortex. If the next step is to motor map primary motor cortex, doing this first minimizes the amount of time needed to motor map, so it helps there. Also, it identifies the best locations to perform direct cortical motor evoked potentials with via stimulating with that cortical strip. Mapping primary motor cortex is never the simple kind of color-coded that we see here, and the anatomy is typically distorted by the tumor. When we perform SSEPs, for example, if we're stimulating the right median nerve and we're recording response from the hand region from left somatosensory cortex, what we're doing is in a typical case where we're using it with a subdermal needle kind of underneath the scalp, and this is the response, the cortical response seen here. So if a 1x4 strip is placed on cortex, each one of those contacts we're recording cortical SSEP from independently. And the cortical SSEP from the contacts over somatosensory cortex will have the similar kind of phase and morphology as the one produced, evoked, or recorded from the subdermal needle under the scalp. But the contacts that are over primary motor cortex, kind of 1 and 2 shown here, or at least anterior to somatosensory cortex, those responses will be muted and flipped in polarity. That's why we call it phase reversal. In this example, that occurs between contacts 2 and 3, and thus the central sulcus is likely between contacts 2 and 3. A couple things to note about phase reversal. It's not always textbook. It can be very dependent on strip orientation. Often the ideal orientation is 20 to 30 degrees off parallel. It's very subject to noise if those contacts aren't making great contact with the brain surface. Once the phase reversal is completed, if it can be moved laterally and stay there, that's great. If it needs to be kind of reoriented and moved more anteriorly, that's fine as well. And also, this would enable us to be able to run MEP or direct cortical MEPs from multiple contacts, not just because now we have potentially multiple contacts in your primary motor cortex or on primary motor cortex, including ones far lateral where we can obtain kind of hand responses and face responses, and then a more medial one to independently obtain kind of leg responses if that's the area most at risk. Make sure it's very secure, as movement can cause false positive changes. If it moves just a little bit, our responses can be lost, and this would be a false positive change because it's not indicative, it wouldn't correlate with dysfunction, just electrode movement. For mapping primary motor cortex, the standard technique in the field these days is using a monopolar ball tip probe, and it's done so with a train of 5 pulses with a 400 to 5 microsecond pulse width and an ISI of 4 milliseconds. Using this electrode, using this probe and these stimulation parameters, if directly on the motor region, the typical threshold is 4 to 11 milliamps. You can go higher, 15 to 20 to 25 milliamps, and if there's no response, then likely distant from primary motor cortex and safe to resect. Safe to resect from a primary motor cortex perspective. If thresholds are 16 to 25 milliamps and the probe is thought to be anterior to primary motor cortex, in possible premotor or supplementary motor areas, if you're getting response at those thresholds, you're probably in those areas. The response isn't due to stimulating those areas per se, but it's due to spread to the primary motor cortex region or the corticospinal or corticobulbar fibers. But that's a kind of a hand wavy assessment of relative location. For subcortical mapping, there's been a few studies which have shown that there's a pretty good correlation between the threshold, the amount of current needed to evoke a response, the threshold, relative to the distance to the corticospinal fibers. So if the threshold is, if you keep going up in intensity and threshold is, you don't get a response until 20 milliamps, then the distance to the corticospinal tract is probably around 20 millimeters, and you can continue to safely resect. But now if the response goes, now if start obtaining responses at, say, 10 milliamps, that's the threshold, then you're much closer, 10 millimeters away. And when the threshold is as low as 3 to 5 milliamps, then you are between less than 5 millimeters away from the corticospinal fibers, and further resection is likely to start damaging those fibers. One thing to note, that with a monopolar probe, using this technique with a monopolar probe, cathodal stimulation, occasionally there will be a low threshold response. We'll get a response at 3 milliamps, and that may be incongruent with the imaging data. The imaging data may say you're still 15 millimeters away. Those kind of false positives can happen. It's rare, but it does happen. And in those cases, you can turn to bipolar mapping to kind of provide an additional assessment. With the bipolar electrode, there's also a pretty good correlation between threshold and distance to the corticospinal tract, and that it's 1 milliamp to 1 millimeter. The only thing with a bipolar, and why it's not done initially, usually monopolar is the first choice, is that bipolar stimulation is more likely to overestimate the distance to the corticospinal tract. So occasionally you'll see thresholds where the threshold is, say, 10 milliamps, but the actual distance is only 5 millimeters away. So this is overestimating the distance to the corticospinal tract, which isn't ideal, because this would inform you that you're still distant and can safely resect a little farther medially, but in reality you're closer than as would the threshold would say. So that's why monopolar first, bipolar to, if as needed, in case there's incongruent data between our thresholds and the imaging data. But I really want to advocate for direct cortical MEP monitoring. So after phase reversal is performed, we can run MEPs through the strip with no patient movement and continually assess function through the strip. And there's been a few papers that have shown that if there's a 50% drop in those direct cortical MEPs, the odds of temporary paresis have increased. And if there's an 80% drop, there's a significant likelihood of temporary paresis and even possible permanent paresis or plegia. So the thing to note from a balancing kind of the maximal resection versus preserving function, if resection stops after a 50% drop, you're much more likely to preserve function. However, you're probably going to get less than total resection. Conversely, if the resection is stopped after an 80% drop, the likelihood of dysfunction is probably pretty high postoperatively, but you're more likely to get a more gross total resection. So it's about balancing that the threshold and the magnitude of the amplitude change can help kind of gauge that clinical decision making. Here's an example where we perform direct cortical motor evoked potentials, and the blue is at baseline. And you notice that we don't have responses from oris or the leg or the foot. And that was done on purpose. We could have gone higher with the intensity at baseline to get those responses, but then if we had gone higher, we know we were stimulating probably a little likely deeper to the primary motor cortex and on the fibers, the sending fibers, and this would reduce our sensitivity to diagnose dysfunction in the primary motor cortex. But in this case, the response on the hand and then the forearm started decreasing. The hand went down to greater than 50% amplitude. Surgeon was alerted, made the decision to continue to resect. It decreased further to about 80%, and was relatively happy with the extent of the resection. And that's when made the decision to stop with the resection and try and hopefully preserve that function. The patient did have significant weakness postoperatively, but ultimately recovered from that weakness. If for whatever reason direct cortical motor potentials cannot be performed, the strip is in the way, it's not working, whatnot, MEPs can provide sensitivity for motor cortex dysfunction as well. However, it's decreased because with transcranial motor stimulation, the stimulation is typically kind of deeper, the effective stimulation. So when we're performing TC-MEPs in these patients, we'll go with a low intensity. The sensitivity is optimizing for diagnosing dysfunction most at risk. So we'll adjust the location of the stimulation electrodes and the muscles that we obtain at baseline to kind of maximize our ability to diagnose dysfunction for the region at risk. For example, if risk is primarily the upper extremity region of primary motor cortex, the intensity may be optimized to obtain responses from just that limb. Note if there's any risk to facial regions, we'll do contralateral orbicularis oris and mentalis, but there is a risk that our stimulation is directly activating the cranial nerve. If we're activating the corticus bulbar neurons, we need a train of stimuli to evoke that response, and that's kind of shown here in that first little short train in the response. You cannot get motor evoked potentials with a single pulse. So if you get it from a single pulse, you know you're activating the nerve directly, the nerve as it's exiting the cranial vault. So here in this case, responses could not be obtained without also getting responses at that intensity to it with just a single pulse. So here, you're not monitoring the corticobulbar tract, you're not monitoring primary motor cortex corresponding to the face. Here, you're stimulating the cranial nerve directly as it's exiting the cranial vault. But if you can obtain responses at a low intensity with a trained stimuli that does not produce responses with a single pulse, then you know the sensitivity for diagnosing kind of dysfunction in the corticobulbar region is much higher. So in summary, if speech, premotor, or supplementary motor areas are primarily at risk, awake with behavioral testing is the way to go. Phase reversal is critical as it reduces the amount of time needed on cortical mapping, motor mapping, and it also identifies the ideal location for direct cortical motor evoked potential stimulation. Should ideally continuously monitor DC-MEPs through the resection and optimize responses for sensitivity of motor cortex dysfunction. If there's a 50% decrease in amplitude, that is a significant alert, and paresis is very possible. And if there's an 80% decrease, that highly correlates with postoperative weakness or potential plegia. The subcortical mapping, there's a pretty good kind of relationship of 1 millimeter to 1 milliamp from a threshold to distance relationship. But there are some pros and cons to both monopolar and bipolar electrode usage, and it's not a strict 1 millimeter. It's like if the threshold is 10 milliamps, probably between 7 to 13 millimeters away, approximately. So thank you. Hope you appreciated this video. Thanks.